hope to make it interesting. So we start off talking about whether there is a right estrogen. So intent of discussion today is going to be the take-home message. And we're going to talk all about the endogenous estrogen, which is there in our body. And then we're going to come and discuss about the exogenous estrogen, and we'll take it forward after that. So I think that would be the end. So these are the references that I have taken. People are interested in the pharmacology of estrogens. I would urge all of y'all to read this very interesting reference from the Climacteric 2005 by Kull. It's an excellent one on estrogens and progesterone. So each one of us who's dealing with estrogen therapy and progesterone therapy, this is a must read. Coming to hormone therapy, I think today's world, now we are more clear about the role of hormone therapy at menopause and the three most beneficial effects, we would agree. The first two, I think, is agreeable with everybody, probably bone health. There are still not a lot of takers, but definitely, yes, all the societies endorse that it is very effective for menopausal symptoms, genitourinary syndrome, and prevention and also management of bone health in the younger, early postmenopausal women. Of course, it has got a special place when we talk about hormone therapy, where it is not menopausal hormone therapy, but then it becomes a replacement therapy in premature insufficiency and early menopause. So the first couple of slides are a kind of take-home message slides. Today we know that the risk versus benefits is what was a big debate over the past decade or more. And this differs according to the age of menopause and also depends upon the health of the woman. I think these are the two major parameters that we need to look into whenever we are prescribing a hormone therapy. So a woman aged less than 50, the benefits of hormone therapy far outweigh the risks, and hormone therapy should be offered. So that means that if somebody needs hormone therapy, generally we would expect the younger woman to be healthy, devoid of any disease, devoid of any risk factors for disease, then it's absolutely safe. Women aged between 50 and 60 with menopausal symptoms, again, the benefits outweigh the risk, provided you have ruled out the contraindications. More than 60, I don't think in India we have ever been prescribing per se hormone therapy beyond 60 and beyond 70. So we need to concentrate in that early perimenopausal and immediate postmenopause period. Very clear concepts in hormone therapy is the timing. The WHI has really taught us this window of opportunity. That means if you start your hormone therapy at a very young age, at an early perimenopausal age group, and that you're maintaining the estrogen benefits, which has been lost at menopause. But, we are going to talk about this during the endogenous estrogen, why some women need estrogen, why some women do very well without any exogenous estrogen. And once you decide that somebody needs estrogen therapy, then it is all a question of personalization. And personalization is tailoring the dose to the patient. No woman is alike. Every woman is different. As different as I know the first time I had written on hormone therapy, way back in 2002, and I had written that every woman needs are as different as their thumbprint. So it's absolute individualization, and later on, as one ages, it is continuation and tapering the dose as the age advances. So these are the basic concepts. So the take-home message is target population for indication of hormone therapy is usually within the first 10 years of menopause, and this we're talking about systemic hormone therapy. When it comes to vaginal hormone therapy for genitourinary syndrome, the vaginal atrophy, you can prescribe it very safely at any age, and you can start it de novo even at the age of 60, 70, 80, 90, if a woman is suffering from urogenital problems. Hormone therapy initiated in the early postmenopausal period in healthy women is safe. Like all medicines, hormone therapy needs to be used appropriately, but it is essentially safe in the early menopause and needed in women who are suffering from menopausal women, and the option should be given for use of hormone therapy. And always give informed choices. When you're talking about informed choices, you're giving them the gamut of medications that you have, the kinds of treatment that you would offer at menopause therapy. And you also need to take a consent if you are prescribing hormone therapy. It is a good idea to take a consent, to give them some material to read about, take an informed choice, call them back, and then prescribe the therapy. But the right dose, the right woman, the right hormone therapy, right route, right regime is all very important when you prescribe your hormone therapy. Now, when you go back to the history of MHT, this book, Feminine Forever, in the 1960s was a big blockbuster, because hormone therapy was projected as a hormone which would keep a woman young forever. Since its first introduction in the 1920s till date, that is almost a century, it has gone through a lot of ups and downs. People are jubilant and they think that this is the best molecule that can ever happen to a woman. But then there are those low phases where, it has produced endometrial cancer, risks of endometrial cancer, risk of breast cancer, and then the prescriptions come down. But then, a lot has evolved over a period of time to understand this very elusive molecule that is estrogen. So let's just go back to what has really happened with the studies that have been done with hormone therapy. In the pre-1998, that is when the WHI study was launched. So we will call it a pre-WHI era and the post-WHI era for estrogen therapy. Earlier, the thought was replacing the hormones prevents or diminishes not only the pathological conditions of menopause, but also the chronic disorders. So there's a little problem with this thought process, because chronic diseases like osteoporosis, coronary heart disease are multifactorial. It is not just estrogen dependent. So you can't expect estrogen totally to completely wipe away or decrease these disorders. But then probably there is some amount of acceleration or an additional risk factor when you have this when you're talking about these multifactorial diseases. But yes, relief of menopausal symptoms, prevention of urogenital atrophy, it's still very good. Now, the adverse effects, even then, that were thought of, where what they knew from the studies was increased incidence of VTE, venous thromboembolism, probably relation to breast cancer, and gallbladder stones. So this was what was thought of. Now, what happened after the WHI? In the 2002 was a time when the release of the WHI was first in the non-medical publicity. And what really happened was the healthcare providers were totally left confused, because not only the providers, the consumers, because everybody thought with the publication that came into all the media that MHT was bad, the risks of MHT outweighed any benefits, and menopausal hormone therapy was bad for the heart, it caused breast cancer, so it is not at all good to take the hormone therapy. And this had happened because before there was a scientific discussion and analysis of the huge data that were collected out of the WHI that was published even before it was properly analyzed and damaged, but the damage was done. And it took more than a decade to analyze and to come to terms. So today we are in a different mode. Post WHI, today the final analysis and subsequent publications and lot of analysis, sub-analysis of so much of data, stratifying according to age, according to disease, and according to the type of cancers, subgroup analysis of the younger woman has really shed a new light on the utility of menopause hormone therapy. Today, the opinions and guidelines provided by the world's leading menopause associations has helped to place MHT in perspective. Just recall the first couple of slides that I have said, so we know that MHT is safe if given to the proper woman at a proper age for a proper indication. And you have to also give the proper route and the proper dose. Now, what is the mystery of estrogen? Why was this actually so much of discrepancy between the observational studies which has happened about before the WHI and after the WHI. One was the wrong indication because the selection of the population in the WHI was mainly in the age group of 60 and above. The average age was 65. And here we always give hormone therapy, or we start hormone therapy for the younger woman. So the population was wrong. And there was a fixed combination. It was only a particular combination of estrogen and a particular combination of a progesterone, which was studied, and a particular dose was studied for a different age group, because the dose would differ for a different population. At the same population, even the same woman at the age of 50 may need a different kind of a dose, and the same woman, as she ages, the amount of dose that she may need would probably decrease and change. And they had not really stratified the risks and then decided who would be given hormone therapy or not. So these were the problems, and that is why there was so much of discrepancy. But now, coming to the moot question today, is there a right estrogen? I would say no, and I would go by it, and I think would agree to me by the time we finish the presentation. So we're going to talk about, so like I said, it's an elusive molecule, and is it a fountain of youth? No. Is it an elixir of evil? No. But HT, as it is, like any other hormone, it has to be used very judiciously. If used judiciously, it remains the most effective and real good therapy for the symptoms of menopause. So coming to physiology, that is the endogenous estrogens. So I hope all of you are with me, because here I would need your attention when we're talking about the endogenous estrogens. I'm sure, all of y'all remember and know, and this is very important for us when we are prescribing the estrogen therapy, because estrogen therapy is much more important for us. It's easier to handle the progesterones when you're talking about menopausal hormone therapy compared to the estrogens. So the endogenous estrogens, which are present in a woman's body that have been discovered to date, as I say, is the estrone, which we call E1, the estradiol is the E2, and the estriol is the E3. Now we have another one, which is called the estriol, which is E4. And this was discovered in 1965 from the fetal liver during pregnancy. And the beauty of this molecule, it is not reconverted into estradiol or estriol. And it has got a huge potential to use in hormone therapy and contraception. And a lot of trials are being conducted, and you may have it in the next couple of years in the market. So going back to the E1, E2, and E3, we know that estradiol is the one which acts at the nuclear and the receptor level, that is at the tissue level, the biologically active form which gives rise to different tissue benefits or tissue effects of the estrogen is the estradiol. The estrone actually is the reservoir form which is carried in the blood, and the estriol is the one which you see during pregnancy. Now coming a little more about this. So we have said these are the molecules. It's all about the hydroxy elements in these three different groups. We know that it all comes from the basic molecule cholesterol. So actually it is the cyclophenanthrene ring. That's the ring, and from there the cholesterol, and from there all the steroid hormones are produced. So we have the estradiol, the estrone, and the estriol, the major hormones. Now what really happens in the reproductive phase? In the reproductive phase, it is the estradiol, that is the E2, which is the most potent hormone. The potency is very, very important during the lifetime of a woman, because that is what acts at the cellular level. And estrone is the lesser potent one, and estriol, that is the E3, is the least potent. And the ratio of estrone and the estriol, estrone and estradiol in a non-pregnant state is 2:1. That is, estradiol is twice that of estrone, whereas estriol is hardly negligible in the reproductive phase. But during pregnancy, you would have more amount estriol that is coming from the during the pregnant state. And why is it so? So nature has really beautifully brought about this different potencies of the hormone. Can you imagine if a woman during pregnancy carried a very potent hormone like an estradiol? What would happen to the breast? We would have umpteen number of breast cancers. We would have so many problems. But the nature is so intelligent. It has produced different kinds of hormones with different potencies in different parts of the life. So during the postmenopause, it is the estrone, which is the major circulating hormone rather than the estradiol. So we come more into it. So when you're looking at the estrogen, it has a reproductive function and it also has a non-reproductive function. All of us are well aware of the reproductive function, but we also know that it is very, very important to maintain certain, receptors are all there, all over the body. It is important for your bone, it's important for your collagen, it is important for your heart. And the target, because we know that because the receptors are present in all these systems. And there are two types of receptors which are present. One is the alpha receptor, and the second is the beta receptor. So we have the ER alpha and the ER beta, which are present in different organ systems, as the picture here is showing you that it is present. And the estrogen receptors have a genomic and a non-genomic element, in the sense that they are affected because of the genes. That means because of the genetic constituents, these receptor activity as well as the enzyme activities inside the cell depends upon the genetics. But the non-genomic activity is, say, supposing somebody is pregnant, somebody is very obese. So what happens? The peripheral conversion of the estrogen increases. So that means you're going to have more amount of estrogen. So there are a lot of confounders, like, you have the suppressors or you have the facilitators, which may increase the production of estrogen or which may decrease the production of estrogen. So stress can also have a problem, have an effect. So also some of the disorders can have an effect. Now this particular picture just shows you the one in the central block is showing you the physiological effects of estrogen, which are very, very important to maintain the breast, the liver, the heart, the uterus, the genitourinary system, the bone, and the collagen. But what happens when the estrogen gets deficient? When the estrogen gets deficient, we know the central effect is the vasomotor symptoms. Then you know that the myocardial infarctions occur more often after menopause than before menopause. And there are a lot of changes even in the lipid profile just after your menopause. Similarly, the periods stop, the urogenital atrophy is there, osteoporosis happens. So these are all these deficiency problems that can happen when the estrogen comes down. But what happens when it is in excess? For women, where the hormones are in excess, the chances of breast cancer are high, chances of uterine cancer is high, chance of gallbladder stones. So you know the fat 40 fair person having those gallbladder stones. Then you have excess of fibroids, excess of endometriosis, the thromboembolism can also be more. So this is what happens when it is in excess. So estrogen tissue level, that is, it is not the estradiol levels which are present in the blood, but it is the estrogen tissue level is very, very important to understand whether this particular woman has a deficiency or has an excess, which translates into the clinical picture that a woman presents with. So at any given point of time in a woman's life, optimal hormone levels are very important to maintain optimum health. So health is never found at the extremes, but very, very beautifully described this so-called estrogen threshold hypothesis. That means there is a therapeutic window. Blood levels between 30 and 50 is what is really necessary when you're talking about the menopausal period. So at this time, the bones are maintained, the heart is good, the urogenital system is maintained, there are no menopausal symptoms. Less than that, you're going to have a problem, especially if it is less than 10. Then chances of urogenital symptoms are very high, with less than 10 picograms of estradiol or less than 10, 15 picograms of estradiol. Osteoporosis happens to be more. he also suggested that the end organ tissue varies in its sensitivity to estradiol. And this is actually very, very important. That is why we don't do the estradiol levels to understand which woman is going to have a problem, because this doesn't really reflect the biological response of a woman to the estradiol levels, because estradiol levels may show whatever the estradiol levels may be showing. Each tissue in the body has its own threshold of estrogen. Now, when we said that, for example, when you're looking at the uterus, in the proliferative phase, the more potent estradiol is there. Whereas in the secretory phase, it is the estrone, that is the lesser potent estrogen is present. So this is how the hormones work very intelligently in different organs. So what happens when E2 is high in the secretory phase? Then you're going to get more amount of the proliferation, and there is no conversion into the secretory phase. So again, the receptor activity at the tissue level is very important. The kind of estrogen that is present at the tissue level is very important. So whatever the blood levels, it is the tissue levels of the active estrogen, the amount that is present actually translates into the clinical picture. So this is what we really need to understand. And now the hormonal changes which happen in the late reproductive phase, you just need to look at these pictures over here. And the one which I have circled in red is the estradiol. Now, during the perimenopause, the ovary starts producing less amount of estrogen because the FSH increases, and some amount of estrogen is coming from the adrenal gland. Now the adrenal gland is producing the androgens, and the ovary also, apart from producing whatever little follicles are left behind, they produce a little amount of estrogen, but then estrogen is coming also from the androgens that has come from the adrenal gland, and in the peripheral tissue, mainly in the fat, the estradiol gets aromatized and gets converted into estradiol, and this is how the estrogen levels are maintained, and it goes into the estrogen sensitive target organs. So the ovary is the main organ which produces the estrogen throughout life. So once it stops producing the estrogen, the other organ takes over, that is mainly the adrenal gland, and the ovary itself, which I'm going to talk to you in the next couple of slides as to how the estrogen levels are maintained after menopause. Now, estradiol, once the ovary stops functioning, which I have shown over here, once the ovary stops functioning, the estradiol is coming from the androgens, from the ovary, from the theca cells, the stroma cells, and from the adrenal. Now, these androgens go to the peripheral fat, get converted into estrogen, and then move on to this. So there is no production from the ovary. The main estrogen is coming only from the adrenal gland and also from the ovary, from the androgens, not as an estradiol. Now, here I'm going to spend a couple of more time on this particular slide as to how estrogen biosynthesis happens in postmenopause. This is very important to understand when you're prescribing your hormone therapy, and also to understand that though a woman, the physiology is the same. That means everybody enters menopause, and everybody the estrogen levels comes down in menopause. That is the clinical presentation. But the way the physiology is the same, but the clinical presentation may vary. Why should it vary? And the various responses at menopause to different hormones that you're giving also varies. So why is it so? Why the biological responses vary in each different individual, and the biological response also varies in the same woman over a period of time to the estrogens. So why does this happen? Because this particular slide actually gives us quite a lot of answers. Now, when you see again, we said that post-ovary, post-menopause, the ovary stops producing the estrogen. Now, by aromatase, the androgen gets converted into the estrogen from the ovary, and then the androstenedione. So it produces the androstenedione, which is also coming from the adrenal. So this goes in the circulation and goes to the peripheral tissues. The main ones is the fat, but there are other peripheral tissues, that is the liver, the endometrium, the brain, the muscle, and the fat, where all of them have this aromatase enzyme, which converts this androstenedione to the estrogen, which estrogen? It's not the estradiol. The first conversion of androstenedione is to estrone. It is actually the testosterone which gets converted to the estradiol. But here it's good to remember that it is the androstenedione which is giving rise to the less potent estrone sulfate, which is the hormone which circulates in the blood, and it is actually considered to be a reservoir of the active estradiol. Now, this estrone gets converted by the dehydrogenase enzyme. Actually, this is the rate limiting step for the conversion to the active estradiol. So this gets converted in the peripheral tissues, then it goes into the circulation as estrone, and because the estrone is not converted totally into the estradiol, it gets converted partially. Now both of them into the circulation, and here again we have this sex hormone binding globulin, which is a very interesting protein molecule. It's a very interesting globulin which binds this estrogen, the active estrogen, that is the estradiol. 98% of it is bound to it. It's only 2% which is free in the blood. That is called the active or the bioavailable estrogen, which is free to actually go into the cells. So it just either passively diffuses into the cell. So there's no receptor at the cellular membrane. It goes into the cell, and there it acts, either it has its receptors at the cytoplasm, then it has the receptors in the nucleus. So once it goes in, the estrone gets again, the estrone and the estradiol, they're interconvertible, and the rate limiting enzyme over here is again 17-beta dehydrogenase. Now this is again affected by so many other factors which are the cofactors. They can be facilitators, they can be suppressors. And when these molecules, the estrogen molecules, are getting attached to the receptors, a ligand is formed. And so there can be a lot of conformational changes in this ligand, this receptor, and the estrogen that is bound. And then that produces different effects in the body. And that is why in some women, it is genetically, they may have different levels of the activity of these enzymes and the suppressors, the co-suppressors, which are the non-genomic factors, which can produce more amount of estrogens. And that is the reason why some of them may have a deficiency, and some of them may be physiologically normal, and some of them end up with cancers of the endometrium and the breast cancer. So the effect in the estrogen target tissue may vary, and it's very, very difficult to check the level of these hormones at the tissue level. It's easier to do it in the blood, but then the blood levels are not going parallel, are not indicative of what really happens at the tissue level, because again, each tissue may have a different threshold of the estrogen activity. And like I said, in the endometrium, the activity may change during the menstrual cycle. Here, during the proliferative phase, the estrogen receptors are higher, whereas when you go to the secretory phase, it comes down. So it's kind of a local paracrine and autocrine functions which are happening. So that is the reason why we are amazed at the activity of the estrogen molecules which we give externally. So that is why it amazes us every time, because the effects are different with the different types of estrogens, with the different types of doses that you're giving, and the route also which you're giving. So a lot of pharmacodynamics and pharmacokinetics are involved with the estrogen, and leave alone that, even the physiological estrogens can produce the different kinds of effects on the body. And apart from this, there is some more additional information that we need to understand if you really want to understand how estrogen acts. It's kind of recirculated. So once the estrogen in the hepatic portal circulation, it gets conjugated. So it gets absorbed from the intestine, and then it is conjugated to glucuronides. Now this has got two pathways for its metabolism. One is the 2 and 4 alpha glucuronides, and they are called the catechol estrogens, which are just excreted and they are not potent. But the 16-hydroxy glucuronide is a very active form, because once it is pushed back into the circulation after metabolism, this binds to the sex hormone binding globulin to a very small extent. So that means it's more free and it is more potent. So women who have this kind of a metabolism, where the estrogen is getting metabolized to the 16-alpha hydroxy rather than the 2 and 4, they have more active estrogen. So though the estrogen levels may not be very high, maybe they are more prone for estrogen causing problems. So coming to the clinical part of it now, we see that during menopause, look at the graph beyond the bar, that is the post-menopause. The FSH is high, the LH is high, and the estrogen levels come down, that is less than 10 to 20. And during the reproductive phase, the levels range between 40 to 400. And what really happens in this slide just shows you that after the age of 35 and to the age of 50, there is a reduction of this estrogen. And then, but the progesterone is also coming down at this time. But then the estrogens are very, very erratic. So the high estrogens sometimes and low estrogens sometimes can give rise to the picture of AUB. So we need to understand that AUB happens not because of any pathology. It's only the changes that are happening at menopause and which can easily be corrected by progesterones. So we call it nature's very intelligent protective mechanism, which I've already alluded to. That means estradiol, the most potent hormone, is present in the reproductive phase. Estrone, that low potency, is present in the menopause, where the ratio of E1 to E2 changes. In the reproductive phase, the E2 to E1 ratio is 2:1, and during the menopause, the ratio is E1 to E2 is 2:1, whereas pregnancy, like we said, the E3. Now, intestines and the to add to all this, there is something called the hepatobiliary circulation and the intestinal absorption. Now, what happens in the intestinal absorption? The intestinal bacteria, they also act in deconjugation of these conjugated estrogens once they're metabolized. So the intestinal bacteria, that is the microbiota, also play a very, very important role on the estrogen levels of the blood. So you have so many factors which influence the activity of the estrogen at the tissue level. So to remember, again, the potency also depends upon the nuclear retention time. That means, finally, when you're looking at the tissue levels, the nuclear levels, again, here, if a molecule is sitting in the nucleus for a longer time, after passing through so many barriers, the estrogen, the active estrogen, that is the 17-beta estradiol, is going and sitting in the nuclear receptor to produce its effect on the organs. There, what happens, if it is sitting for a longer time, the potency will be more. But if it stays there for a very short time, then the potency is very short. So that way, estradiol is 10 times more potent than estrone and almost 80 times more potent than estriol. So this is the changing ratio that I've spoken to about. So to sum up, the variable physiological response that a woman has at menopause is very, very different. And that is because the distribution, the heterogeneity and functions of alpha and beta receptors are varied. Aromatization of androgens to estrogens in various tissues are different. And there's always an interconversion of E1 and E2 at different levels. And degradation right from the intestines. Like I said, the presence of this microbiota differs in different women. The bioavailability of these estrogen again depends in the circulation, the levels of the sex hormone binding globulin, which again depends on so many factors. The final response depends upon the tissue levels of estrogen and the time that this estrogen stays at the nucleus. And the biological activity of the sex steroid metabolites are the last and the final addition to this varied response. So I hope all of you are with me and I have not put you off to sleep, because now we're going to move on to the pharmacology. And I promise you that this is not going to be as complicated. Now, so we're going to talk about what happens to the exogenous estrogens that we are giving. This is very important for us to know, because this is what we prescribe. Now, but that basic was very important to understand if you have to give the right prescriptions. So do you agree with me now that there is nothing called a right estrogen, because this has got a varied molecules and it is very, very different from other hormones like the insulin or the thyroid, because insulin has got only one format. Thyroid has got one form, but then estrogen has got so many different facets to it. So we cannot, that is the reason why it is simpler to prescribe probably the insulin and thyroid, where only the dose varies along with the weight, but it doesn't vary so much with the age, unlike your estrogen. So estrogen is definitely much more interesting molecule. Now, natural estrogens that we have, that we can use for menopause hormone therapy are the native estrogens, that is the 17-beta estradiol, the estradiol valerate, the estriol, the estriol, which is going to come in, and then these are all the natural ones. The conjugated equine estrogen also falls into the natural estrogens, where it is produced from the pregnant mare's urine collectively, and then the molecules are formed from there. What are the synthetic estrogens? The synthetic estrogens are the ones which we use so commonly in the oral contraceptives, and that is the ethinyl estradiol. And why are they so different? What is the difference between natural estrogens and the synthetic estrogens? Why do we not prescribe ethinyl estradiol versus the natural estrogens during your menopause hormone therapy? So I think we will have the answer at the end of the session. The potency, here when you're prescribing these hormones, estriol is the least potent, conjugated equine estrogen is a mixture of hormone, and estradiol is 80 times more potent than estriol. So having understood this, it becomes easy for us to know how we have to prescribe these different kinds of hormones. So the potencies of the hormones can also be compared in terms of their ability to suppress the hot flushes, to increase the HDL, their effect on the angiotensin, and the effect on the suppression of the hormones. So when you're looking at the estradiol, supposing 100 potency, it's 100 potency is needed to suppress the hot flushes. Estrogen, ethinyl estradiol is 12,000 times more efficacious actually. And the HDL that is needed to increases the potency is 4,000. So the ethinyl estradiol is a highly potent molecule when you compare with estradiol, when you compare with conjugated equine estrogen. Estriol, it's only very, very low potent, that is only 30 and 20. And the amount that is needed to suppress the FSH with ethinyl estradiol is also between 80 to 200 compared to only 1. So estradiol and the CEE, that you need only 1 to 1.1 potency to suppress the FSH. That is the reason why in certain cases of premature ovarian insufficiency, when you are giving MHT as a therapy, you have to tell them that they can still get pregnant because that's not enough to suppress the FSH. Whereas if you're giving ethinyl estradiol, it suppresses the ovulation. So these are different levels comparative, the doses that you like to give when you compare the conjugated equine estrogen. When you say standard dose of conjugated equine estrogen, 0.625 Premarin would be 2 milligrams of 17-beta estradiol, would also be equivalent to 2 milligrams of estradiol valerate, and transdermal, it would be 50 micrograms of transdermal therapy. So it's not just the dose or the different hormones which have differential effect, but oral hormone therapy also differs because of the dose and duration. So now let us look at the effect of the oral hormone therapy versus the time duration. And so this is its effect on the venous thromboembolism. The duration, that is in the first 1 year of therapy, the maximum amount of problems can happen. That is, the thromboembolism generally happen more in the first year of therapy versus beyond 1 year of therapy. And it is dose dependent. That is, smaller amount would cause less amount of problems compared to the higher doses, which would cause more increased amount of VTE. Similarly, when you compare this analogy, conjugated equine estrogen 17-beta estradiol would also cause less amount of problems with the venous thromboembolism when you compare with the ethinyl estradiol. Ethinyl estradiol would cause more amount of venous thromboembolism episodes compared to the natural inhibition. So genetic or acquired differences are different. The intestinal absorptions are different. External factors are different. There are so many disorders which can give different problems, and the pharmacodynamics are different. That is why it is. The route is different. That means when you're giving an oral treatment, there is a increase in the blood levels immediately within 4 hours, plateaus around 6 days, then becomes plateaus of over a period of 12 hours. Whereas transdermal, there are peaks and troughs when you're giving a percutaneous level. So the route also matters. It's not just the levels, but then again, when you compare the estriol, when you're giving a vaginal estrogen therapy, 0.5 milligrams, it doesn't increase the estradiol levels much. The estriol levels rise to a certain extent immediately, then fall immediately in the blood. And it's pretty safe to give the vaginal estrogen therapy. But when you compare the absorption of ethinyl estradiol versus the natural hormones, whether it is estriol or whether it is conjugated equine estrogen. So if you're giving a conjugated equine estrogen vaginally, the blood levels of estradiol do not rise much, nor does it happen with the estriol. But if you're giving the ethinyl estradiol vaginally as a contraceptive, when you're giving, say, a ring for contraception, or you're giving it as a tablet form, ethinyl estradiol would cause the same amount of effects everywhere on the body because of its intrinsic molecule. So the hepatic bypass doesn't really work for that. So we need to understand that when you're giving a systemic hormone therapy, the actions are very different. When you're giving a local therapy with a reduced dose, the actions are very different. Whereas if you're giving an ethinyl estradiol orally or vaginally, the actions and the side effects are the same. The effect on the lipids are the same. The effect on the blood pressure is the same with ethinyl estradiol. So this is a very important thing to understand. And that is why we are not going to prescribe ethinyl estradiol as a hormone therapy in the menopause and postmenopause. In the menopause and postmenopause, it should not be the OCPs. It has to be the MHT. And then the route of administration is very important. Like we said, the non-oral route actually bypasses the liver circulation. So that means the good effects also, the effect on increasing the HDL will not be there. But then there is the increased triglyceride effect is not there. The increase in the C-reactive protein is not there when you're giving transdermal factors, nor there is an increase in the clotting factor or the sex hormone binding globulin. So these are the good effects when you're giving the transdermal, because the oral, which passing through the liver, actually also produces these side effects. So that can be prevented when you're giving a transdermal route. So that is how, clinically, whenever there is a history, whenever there is a woman with a high risk for thromboembolism, say she's very obese, her sex hormone binding globulin is very low, and then you want to also she may be suffering from a gallbladder disease, then these are the ones where you need to give a transdermal rather than an oral therapy. And we know that oral therapy, transdermal therapy, oral estradiol therapy, oral conjugated equine estrogen, oral estradiol, both of them increase the HDL, which is so important when you're talking about cardiovascular protection. But then this effect is lost when you're giving your transdermal. So that is why it is very important to understand how to stratify the woman and how each woman may need a different kind of a therapy, not only the type of therapy, the dose, and also the route of therapy. So this is a common picture which I'm not going to talk about. And again, transdermal therapy would do away with the thromboembolism effects, and it is probably safer to give whenever you have a high risk for venous thromboembolism. And the type and dose of progesterone when you're adding in for a woman with uterus also matters. Say, example like HDL. HDL, when you're giving conjugated equine estrogen alone, it increases the HDL values. But if you're giving micronized progesterone, it decreases, the pink one, decreases to a smaller extent. But if you're giving medroxyprogesterone acetate, which is a more of an androgenic molecule, then what happens? The effect, the increase of HDL is blunted. And so that is what you found in the WHI trial. So there's a blunting of the good effect of the estrogen when you're adding an androgenic hormone. So probably a micronized progesterone or a dydrogesterone would be much better and more metabolically friendly when you're giving along with this thing. Now, coming even at the tissue level, the estradiol levels and the cellular response varies. This is a very beautiful slide where you're looking at it on the left side, you're actually looking at the cortical bone. On the right side, you're looking at a trabecular bone. And down at the x-axis, you have this E2 levels, and the vertical axis, you have the bone mineral density. Now, by looking at the estrogen levels, even at the level of 25, between say around 30 picogram ml, the cortical bone is well maintained. But you see, at the level of 30 picograms, the trabecular bone starts falling. And that really what happens. The postmenopausal loss is initially at the trabecular bone. And only once the menopause happens, much later in life, when the levels fall down, maybe up to 75, it was fall down much lower, then the cortical bone loss, that is the age-related bone loss, happens. So even at a tissue level, that means each cell may behave differently to the different levels of estrogen that is present. So synthetic estrogens should not be given for MHT, exception is early menopause and premature menopause. So is there a right estrogen? Individualization is very, very important. So you see again over here, this is, I think, probably one of my last slides, where the effect of different estrogens on the hot flushes. Placebo, no effect, no decrease in the hot flush. Estriol, 2 to 4 milligrams is needed, not too effective. Leviol is effective, estradiol valerate effective. Conjugated equine estrogen 0.6 to 5 works really well. Very potent hormone, because it's not just the conjugated equine estrogen, but its metabolites also work well, and that is how the dose differs. Again, it's the age. The age matters for its beneficial effect. The WHI has clearly shown hormone therapy early period, effective, later period, it is bad for the heart. Similarly, the breast, the type of progesterone is important. So thank you so much for listening in, for tuning in this lockdown period, you know, from the very comfortable zone of your home. And I hope I've not bored you too much with the pharmacology and physiology, but I enjoyed presenting this particular session. Thank you all.